Assalamu alaikum warahmatullahi wabarakatuh جميعا. Today we'll begin talking about systematic reviews and meta-analyses. I'm gonna give an introduction about the topic initially, and then I'm gonna talk about defining the question in a systematic review. And then I'm gonna focus on the search strategy, how to perform the search, and how to save your search. So let's start our presentation. The objective of the talk is to get an overview on systematic reviews and meta-analyses, learn the basic concepts and terminologies that we use in this kind of research, be familiar with the steps involved in conducting systematic review and meta-analyses, the general steps, of course, and learn about the tools needed for an effective search strategy. So let's talk about the journey of conducting systematic reviews and meta-analyses. So usually we start with formulating the research question, preparing your protocol, searching for studies, screening them, and then extracting the data from the included studies, combining studies together, analyzing the data, and then finally presenting the result. This is really just a quick overview on the journey of systematic review and meta-analysis. So let's start our first lecture. We're going to have define what are systematic reviews versus non-systematic reviews, the benefit of systematic review compared to single studies, what's the review question, and the process of conducting systematic review and preparing your protocol. So let's start with the beginning. If we only knew what we know, the systematic reviews, and really not that new information. It's just information that's out there. We know it's out there, but it's just we're combining them in one study. And anything you can do, I can do meta. So if you can do cross-sectional studies, if you can do RCTs, if you can do observational studies, we can do those, and we can meta-analyze those and combine them together in a meta-analysis if possible. So why we go to that extent? Why do we combine studies that are already there, already published? Really because there's an information overload. We used to start with maybe a single books in medical literature. The books became bigger and larger and more, and then we had a lot of medical journals, and then now all the journals, everything is online, so there's a lot of information out there. There are 75 trials and 11 systematic reviews a day, and that's even an old study that I'm referencing. So really, there has been in the 90s a boost for systematic reviews and meta-analyses. There are different types of reviews and systematic reviews. The white circle, the big circle, are all reviews. We also call them overviews. The yellow circle is the smaller one inside. These are systematic reviews. So they're part of the reviews, but not all reviews are systematic review. And then the smaller white circle inside the systematic review, these are meta-analyses. So some systematic reviews can even be further explored into meta-analyses. And the very small blue circle inside the meta-analyses, something we called IPD, individual patient data meta-analyses, in which we combine individual patient data, raw data, not just published data. So what's the difference between a systematic review and traditional reviews? So traditional reviews, also we sometimes call them narrative reviews, give a panorama, or it gives us just an overview on the topic. Covers the topic in general, like textbook, give background information, some knowledge information, what is the disease, how we can manage it. It's susceptible to bias because of the selection process, and there is no quality assessment. However, the systematic reviews give a telescopic view on the topic and addresses usually a specific question or more than one question. Focus on foreground knowledge, uses rigorous methods for searching to minimize selection bias, and there is a quality assessment technique or methods to be done to minimize or to assess the bias in included studies. Meta-analyses is just a statistical technique in which you can combine two or more studies together statistically. So it's a next step of the systematic reviews. Of course, you cannot conduct it unless you have enough studies that are similar together. Advantage, they provide more precise estimate when you combine studies together, so you get a more precise numbers and assess the consistency across studies. All reviews, you have to know that's the limitation, all reviews, narrative or systematic, are retrospective in nature and observational because this data is already published. and they're subject to systematic and random error like any other research. So what's the benefit of systematic review compared to single studies? Really, it saves the reader time, provides reliable evidence, resolves inconsistency between studies. It can identify gaps, establish the questions that have not been fully answered in the medical literature and clinical studies, and explore differences across studies. So why do we need systematic reviews? They provide up-to-date summary of all published research literature, allow large amounts of data to be assembled together, and provide an objective collation of results of the research. It's inform and provide reliable recommendations for clinicians, policymakers, clinical practice guideline developers. So let's focus on the review question. What type of questions we can do in a systematic review? Really, anything can be done. So any intervention question. What's the efficacy of an intervention? What's the risk of this treatment? Any diagnosis test accuracy reviews, we can do that to provide a more reliable estimate for diagnostic testing. Any prognostic reviews to assess the probable course of future outcome of people with a specific health problem or a specific increase in certain biomarkers. We can see how that biomarker affect health outcomes. We can do methodological review to assess questions about the research. Let's say I want to do a systematic review on the quality of the reporting in RCTs, specifically on the randomization process. For example, how confounders were adjusted for observational studies in a certain question. So it can be the review that the benefit of it is just methodological. It could be a qualitative review, synthesize evidence from interviews, focus groups, and addresses questions other than effectiveness. So what's the right question to ask? They're always thinking of the right research questions is something critical, and we think it's like a very important step in our research. Really, make it easier in defining your question. Always have it in a PICO format or a PICO-D or a PICO-S. P for population, I for intervention, C for comparator, O for outcome, S or D is for study design. Doesn't matter if you call it S or D as long as it's for study design. This is an example of a well-formulated question. What is the 2-year overall mortality in patients with prior MI taking 2 grams per day of fish oil supplement compared to 2 grams per day of ALA oil? So you can divide these in the PICO and figure out which one is the population, intervention, comparator from this simple and easy question. The 4 components, PICO components, are all important, but they do not need equal emphasis in every review question. So it depends really on your question. So every element of the PICO is important. Sometimes my question has no, let's say, comparator or has so let's take an example. If you're interested in exploring which of the various competing intervention works best for a particular stage of breast cancer, which PICO element should be defined very precisely in your question? What do you think? So you want a particular stage of breast cancer, that will be your population. And then you can talk about the interventions. You're really not interested whatever the comparator is. So your PICO here is mostly focusing on the interventions and the patient population. So what's the process of conducting systematic review and meta-analysis? So first of all, you need to define the question, as we said, in the PICO format. Population, intervention, comparison, and outcome. And then you're going to search the literature, which will be our focus, inshallah, today in our talk. There's Medline, Gray literature, hand searching. We're going to go through all of these elements. And then after searching the literature, you're going to pull the articles, screen them. So first, we're going to screen the abstract using the inclusion criteria from the PICO that we have. And then we need 2 people to independently screen all the abstract by minimum, and a 3rd person to resolve any controversies or any discrepancies. And then you're going to, after screening the abstract, the studies you say yes at that stage, you're going to pull their full text and again screen them, again using the same duplicate format by 2 people independently. And then once you decide which studies you want, you're going to move to 5th step and then extract or abstract the data from these studies and assess the quality at the same time. All of these, the step 3, 4, and 5, require 2 independent people to do everything simultaneously, and then a 3rd person to resolve any discrepancies. And then finally, if the data can be combined, we're going to do a meta-analysis and combine the studies together. Who needs to be involved in a systematic review and meta-analysis? Usually need an author team for double checking to get different perspectives and to get their different experiences. What's the time usually conducted? What do you think the time usually conducted to do one systematic review and meta-analysis? According to the Cochrane Collaboration, on average, it takes 30 months to conduct. Even that's more than that about 2+ years to conduct systematic review and meta-analysis from the moment of writing the proposal to publishing the manuscript. That can sound like a big of a large, a long time. Now with the more advances in technology and the help of technology, some of the things we can do a little bit faster instead of manually doing some of these steps. So hopefully this time frame is getting less and less by time. So you will need to obtain full text article of all the studies included. What do you think is the median number of studies included in a Cochrane review? Do you think is the average number? The average is 10. It's not a lot. So all of this 20, 30 months time for 10 studies, yes. Because it's the process is a really long process and a very thorough, it has to be a very thorough process. How many authors do you think you need? On average, Cochrane says 5 authors are needed in a systematic review to be conducted. There are several software that we might be talking about through our lecture today and other loading dose lectures that are important for systematic reviews, such as the Abstractor, SRDR website, RevMan, R, Comprehensive Meta-Analyses, and Open Meta. Some of them are tools for extracting data, some of them are tools for screening, for quality assessment, and some of them are tools for data analyses. Then let's finish our lecture 1 by talking about preparing your protocol. Why do we need a protocol? To ensure transparency of the data. So you're transparent, you say your plan and you follow your plan as you said it. It limits the biases, it ensures accountability, and avoid duplication. If there is a protocol published, why would I do something that is already, there is someone planning to do the same? So people try to avoid doing the same kind of projects. There are 2 different ways usually in systematic reviews to publish protocols, either through the Cochrane, but through the Cochrane it has to be from the beginning an agreement with them. We're not going to talk about the process. Not every review is through Cochrane. There is a certain steps and approvals that you go through if it's going to be through Cochrane. And if it's not through Cochrane, anyone can register in something called Prospero. It's a registering website for systematic reviews. Cochrane, it's a collaboration named in honor of Archie Cochrane, a British researcher. It's a British charity formed to organize medical research findings as to facilitate evidence-based choices about health interventions faced by health professionals, patients, and policymakers. And it sets guidelines, and it has the risk of bias assessment tool for RCT. There's so many things under Cochrane that we use to conduct systematic reviews. And once Cochrane was established, the foundation, there are more reviews were being conducted worldwide because they established the rules and the guidelines and the steps, general steps. And they have a guideline book that I really, really recommend, the Cochrane Handbook for reading systematic reviews and analyses. Prospero, it's a site to register systematic review. Anyone can register. It's for free. It's an international registry, provides a public record of planned methods, raises awareness of the review, tracks use and impact of published reviews. It's a permanent record whether there is a final report published or not. And usually now, most journals will require that you have a Prospero registration number before you publish your manuscript. And so I highly advise you, if you're planning to do a review, once you have your proposal ready, is to publish it in Prospero. You need to write the background, you need to describe the condition of the health issue, describe the intervention, how the intervention might work, and the importance of the intervention. And then you need to talk in the method section, describe your planned methods, anticipate finding sufficient studies, and if you're going to do a meta-analysis, and don't exclude studies unnecessarily. That could be in your plan. And then you will put your PICO First, you're going to define your population. These are examples of, for instance, narrow population, patients with histologically or cytologically confirmed lung cancer of non-small cell type, locally advanced or metastatic, and with thoracic symptoms. So this is a very narrow population. It's not a right or wrong, it's just knowing the more narrow, the less likely you find studies. Broader the population, we included adult participants of 18 years older with cancer-related pain. We defined cancer-related pain as pain directly linked to the development of cancer and not due to pre-existing pathologies or related treatments. You can even make it a very more broader question. All men enrolled in studies of prostate cancer screening were eligible for this review with no exclusion based on ethnicity, age, or presence of lower urinary tract. So these are just different ways of asking how you can define your population and then define your intervention. You have to can be narrow versus broad definition. Consider combined intervention. So are you talking about one treatment or it could be two treatments together? Defining the comparison. Think of relevant comparisons, placebo, usual care. Again, broad versus narrow definition. You have to have a definition regardless of broad or narrow. I'm not saying it can be one or the other. It's just you have to have one. So you can say, like, my intervention is X medication in this dose, in this frequency, in this duration. Or you can say, my intervention is X medication regardless of dose, frequency, and intervention, and so on, and the same for comparison. And then define your outcome, report the outcome importance, choose the standard outcome as much as possible, and always include adverse events if you can. Avoid selecting outcomes but based on available in the literature. Try to choose the outcomes that are important for that disease state. You can use and try to avoid using short-term surrogate outcomes. You want long-term hard outcomes that are more clinically relevant. And how the outcomes are measured, you should know that, you should specify that. Please specify the follow-up. Is it short or long, or is it any follow-up? Are you going to use published validated measurements or instruments? You have to specify. Let's say your outcome is pain. So which scale have to be published so you use it? And so what are the scales that are acceptable for you for pain outcome? Plan a hierarchy of measures if you can, like, so it's your primary, secondary, and so on outcomes. The design. So usually we choose RCT if it's an effectiveness kind of question or efficacy related question. But sometimes we cannot choose an RCT. It's not really our question. It's impossible to have an RCT. Let's say, for example, seatbelts. Whether seatbelts prevent accidents, government regulations and health insurance, effect of sewage, for example, adverse effects of long-term, facilitators and barriers of accessing or completing the tuberculosis treatment, cost effectiveness. All of these usually RCTs are not acceptable. Now we're going to talk about the second part of the presentation, the second lecture, which is searching for studies and screening studies. First, we're going to talk about sources of search, designing a research strategy, managing the references and reporting the research, the importance of a detailed search strategy, and screening your studies. So what should you look for, or where should you look for, basically? You should have a comprehensive search, have a detailed terminology, include the databases you want to search. You search the gray literature, like conference proceedings, dissertations. We're going to discuss this in a few slides, and search unpublished studies like unpublished trials and registries, for instance. Recommended database. The Cochrane actually recommend at minimum these three databases: PubMed, Embase, and Cochrane Central Register for Controlled Trials. You can supplement your search, or you should supplement your search. It's not actually optional. Hand searching for selected journals and conference proceedings. Conduct author searches for recent articles written by topics and experts in the field. Contact authors if needed. You can have search supplementary database. Depends if you need it for your question, such as Scopus, Web of Science, some specialized databases, for example, PsycInfo or Physiotherapy Evidence Database, or SNHAL, I think it's for nursing. So it depends if your question in a specialized area, you can use a specialized database. Gray literature, these are things like conference proceedings or abstracts. When they're published in a conference, but they're not yet published in a manuscript, we call them gray literature because it's neither published, neither unpublished. So it's out there, but it's not in a full text format. You can either in Google search conferences. If you have Embase, using the keywords you're going to search, it can automatically search some of the conference proceedings related to the conferences of your question. For example, my question is an ACS or acute coronary syndrome. So conferences related to cardiology, Embase can do the search automatically. So, but not everyone has access to Embase, unfortunately. Unpublished literature, you go to registries like clinicaltrial.gov or any registry for clinical trial, WHO, European Registry, Saudi FDA, and you can search the registered clinical trials and compare them to the published trials that you found and see if there's something that's registered and one not published, and that's unpublished research. So how should I search these databases? So now you're going to design your search strategy. Identify the maximum number of relevant studies. That's the reason we do this. We want to design a search and try the maximum, not the minimum number. It has to be systematic, transparent, and reproducible. And when you publish it, if I want to go and check it out, I can look at the published methods you have, the dates of the search. I can redo it. I should get the same numbers you had. Data-specific controlled vocabulary terms and all relevant text words should be included in the search strategy. For example, DVT, deep vein thrombosis, venous thromboembolism, and so on. So looking at the PICO elements, which PICO elements you think is most important to be included in the search strategy? So you don't have to include all the PICO elements or all the keywords related to the PICO question in the search. The most important include the population, the intervention, and sometimes the study design. So that really depends on your question. But these are the three usually common ones. Sometimes you include the comparison if it's very important. If let's say I'm comparing warfarin versus a heparin, so I need warfarin intervention and I need the comparison to be heparin. So I need that keyword to specify these keywords in my search. The least actually keywords we use in our search is the outcome, unless the outcome is very important. Let's say my outcome is COVID-19 vaccine and myocarditis. I only want myocarditis. So I include that, and I have to include myocarditis related terms in my search. So really, you don't need to include all the PICO elements in your search or the PICO element in your search. It depends on your question and the importance of each of the elements in your question. You have to turn concepts into search terms. Imagine that you are working on a thematic review and entitled Helmets for Preventing Head and Facial Injuries in Cyclists. What should be the population of interest? What's the intervention? So the population is cyclists, the intervention is helmets, and the study design could be RCTs. I'm not sure, but you should specify these and change the question into the possible keywords. You should have the meta terms and synonyms and the possible keywords. You can use the medical subjects heading in Medline, and you should know, like, for example, look at the second statement here, young adolescents. So instead of having adolescents with an S or adolescent, you can just say adolescent and then a star. So it means a star here means anything after the S, any letter after the S will be included as a word. Teen or teens, instead of writing teen and teens or teenagers, you just write teen and then a star. Child, children, so a star will be enough. And so star end of the stem of the word will be automatically search for all the endings for that word stem. So for example, child will also return children, childbearing, childbirth. So you have to keep that in mind. Do you want that or not? You should keep that in mind. You search for the word variants. For example, AIDS. There are different variants: acquired immunodeficiency syndrome, acquired immuno, and then there is a dash, deficiency syndrome, acquired immune, and then space, deficiency syndrome, acquired immune deficiency, not immuno. So you should think of all the possible word variants, all the synonyms, newborn, infant, toddler, etc., all the plurals, you should think of these, all the spelling variants, UK versus US, for instance. This is an example of a research question. What is the best timing to start metoprolol infusion in patients with STEMI? to improve outcome. So let's change it into the PICO format, the population, intervention, comparator, outcome. So my population here is STEMI patients. Intervention is metoprolol infusion early. Comparator is maybe late intervention. And the outcome is CVD or cardiovascular outcomes. We're going to change those into keywords. So you have to have a detailed keyword for the population. This is just an example, not all STEMI keywords. It's just an example of some STEMI keywords. And then keywords related to the metoprolol, early metoprolol, beta blockers, and maybe you can list all the beta blockers if you're interested in all of them or as a group. And the comparator also, you should do the same for the comparator. And these are the detailed keywords for the outcome. And then you're going to combine the keywords with either or, and not. I think this is maybe have covered in other lectures. I'm not going to go through details. Here, everything in each component of the PICO is combined with an or, and then we combine each PICO with each other, the P with the I and C and O with an and. And of course, I said sometimes we can search all the PICO keywords. We can choose on population intervention, comparison, population intervention, and study design, and so on, depends on what's important in my question. This is an example of keywords for RCTs only, keywords related to randomized controlled trials. These are 22 keywords related to randomized controlled trials only. I searched OVID, Medline, and I just screenshot some of my my view here so you can see what I've done. First, I opened OVID. I have access of OVID, and then OVID is just a website that can make it easier for you to search Medline instead of PubMed. And it's not for free, so you have to have a registration, usually institution. You cannot just as an individual go and register in OVID. So I enter OVID. There are several databases. You choose a database you need. For instance, here I chose OVID Medline, and I chose the most updated version of the OVID Medline. It also includes all the publications ahead of print and from inception of OVID, from inception of Medline until the latest or the most recent date. Of course, there are other things you can. There's the Cochrane Central Registry. It's available. For instance, here I can choose it. If the Embase is here, I can choose it. So there are other databases sometimes available in OVID, and so you can choose other databases if you need them, and of course if they are available. And then I entered the keywords I need. For instance, for this question, first I entered the population keywords, and population were COVID patients. So I entered keywords related to COVID. And at the end, I have the word TW, means text word. Whenever this is a text word within the document, it will find the paper that has, for example, COVID as a text word. I can, instead of TW, I can say TI. TI means title. So I want anything that's in the title has to have COVID. Of course, title means I'm limiting my search, only things that have these keywords in the title. So that's usually not acceptable in a systematic review. To know, like, did I choose TW, title, abstract, and OVID itself, you can go inside and it can tell you what does this mean, TW and other abbreviations, what do they mean? Usually we choose TW means text word. And then we enter also keywords related to the intervention. For example, here it was tocilizumab. We combine, if you can notice, we combine in each, the population, they were all combined with or, and the same thing for the intervention. The same thing for the comparison. It was with corticosteroids and it was combined with or. And then that was my question. My question was, what's better, tocilizumab or steroids in patients with COVID? I did not define in my question the study design. I did not define the specific outcome. So this could be sufficient to run my search. Now I combine them together, 1, 2, and 3. So the population, intervention, and the comparison together. And I got about 200 something studies. In this stage, I can remove duplicates. I don't have it here, the option to remove duplicates. Why? Because I only search one database, Medline. If I search multiple databases at the same time, for example, Medline and Embase or Medline and Cochrane, I can remove duplicates. And then you should select the studies I got, all of them that I got, and export them in whatever format I need to export it. I want to export it to EndNote, to Excel, ref work, whatever the reference manager, however, usually I export it as Excel, and then from there I take it further. You can export the abstract, the title, the author name, whatever information. Once you click export, you can choose the format you want and the details you want in the export. So after running the search and exporting the data, for example, in an Excel, you need to manage them, putting them in a reference manager, or you can use as simple as Excel, by the way. One of these reference managers, EndNote, can be useful in removing duplicates, especially if you're searching different, let's say OVID, and you're searching Google Scholar and you get from different places. So a reference manager can help you remove duplicates. Document the search process. Very important. Don't forget from the beginning, database use the date search, because at the end you're going to forget. I ran my search today, and then I come a week later, said, when did I do the search? I forgot. So document all the search dates, the search strategies, the limits you use, any limits, any publication limits you use. Document this. So why is it important to do this? Why is it really necessary to go through all these details? Yes, it is important, and it's important to search in one database. As I said, it has to be reproducible. One of the key elements of systematic review define it differs from or makes it unique or more robust than a general review or a narrative review is the comprehensive search strategy. It limits the selection bias. So you cannot do that unless you have a detailed and a transparent search strategy. This is a study that looked at either standard search versus extensive search and found if you did how different search strategies impacted the number of randomized RCTs retrieved. RCTs on the effect of acupuncture, for instance, and then there's also RCTs on the effect of lipid-lowering agents. They found if they did extended search, they had 9 studies, for instance, for acupuncture. The major databases, they did 12. An entire bibliography, they got 21. Look at the differences also in the lipid-lowering agents. Only an extended search was 85, and major databases 176. And looking through entire bibliography, or like hand searching the included studies, searching OVID, Medline, and Embase, for instance, they got them 361 studies. So you get different number of studies when you extend your search. How will authors report search strategy? Percentage of reviews reporting on selected items to assess search strategy. They found that at least two databases search 56% of the time. Search terms described only 53. Search strategy described only 47, unfortunately. Gray literature searched only in 14. Hand search performed only in 8. Hand search is necessary. Hand search means that when you include the studies, at the end, the full text you included, you have to hand search the reference list and see if there's any eligible study that you have missed. That any study that defined language restriction was 8. Any study that tried to contact the author 4. You should try to contact authors as much as you can, even if they don't respond. Try to contact them. In my experience, maybe if I contact 10 authors, at least one would respond and give me further information that I need for my systematic review. Interface reported, like the databases and so on, was reported more frequently by authors. Screening studies. So after you get the search, you exported the data, the studies you have, you're going to screen them. There are 2 stages in screening. First, the first stage is screening the titles and abstract that you got. Check if they meet the eligibility criteria, PICO criteria, done by 2 or more investigators. I mentioned that previously, double screening. And then once you know what studies you want to include, you do the next step, which is full text. You pull now the full text of these eligible abstracts and titles and apply the same eligibility criteria, again conducted by 2 investigators independently at least. There are different tools to search titles and abstracts. You can search them through EndNote or any reference manager, through Excel. And there are websites such as I use Abstractor. It's a free website. You can enter it, log in freely, and there is easy descriptions of how to use Abstractor. It's and I highly recommend it. I use it all the time, and I find it user-friendly for me. And then at the end, I just want to finish my presentation talking about the PRISMA flow diagram. This is it's very important to document the search strategy. It maps out the number of records identified at each step, and why did you include, why did you exclude? Maybe I forgot to mention this. In the title and the stage of screening the title and abstract, you do not need to mention the reason for excluding studies. But however, at the end, when you're looking at the full text screening, once you full text screen studies, you need to give me the reason for excluding studies one by one. So, for instance, in our example, we had 280 something papers. Let's say I screened them and I think 50 abstracts were eligible. So I pulled the full text of 50 studies and I reviewed the 50 studies. And then the 50 studies, let's say I found 10 of them unrelated intervention. So I put that's the reason. So I have to specify the reason at that stage, at the full text screening stage, and that should be documented in the PRISMA flow diagram. There is an updated flow diagram for PRISMA. Well, in other lectures, we're going to be talking about the PRISMA in more details. The PRISMA is just reporting standards everyone has to follow when they report systematic reviews and meta-analyses. Inshallah, in other lectures, we'll talk in more details about the PRISMA and the updated 2020 PRISMA guidelines or for reporting systematic reviews or standards for reporting systematic reviews and meta-analyses. I hope you enjoyed the lecture today, and it was just a start and really helps you think of the research question or the meta-analyses, systematic review meta-analyses, and how to search the literature. Inshallah, in other videos, we'll be talking about data extraction and maybe further on move through data analyses and finally reporting your study. Thank you so much for listening.